Setting up a CVI clinic. As Robertson Davis says, the eye sees only what the mind is prepared to comprehend. Cerebral visual impairment, also in the wider sense, is the impairment of vision due to problems in the vision center of the brain, which cannot be explained just by the ocular problems and is often associated with eye movement disorders. This video is our attempt to simplify understanding this complex visual problem in children and help each one of us in setting up our own space. Let us first understand why we need to know about CVI. CVI is the most common cause of permanent visual impairment in children. Improved survival of children with severe neurological damage increases the chances of encountering children with CVI. This impacts the child's psychomotor, educational, social, and emotional development. What do we need to know about CVI? It is this whole process of how a person recognizes and understands the whole world around him, and our brain plays a very vital role. The neural processing of vision involves two principal higher pathways, the ventral stream or the what pathway and the dorsal stream or the where pathway. Visual function is served by the various lobes of the brain as shown here. Under this umbrella of CVI, child could have various visual dysfunctions as shown here. The spectrum of visual difficulties can range from a profound visual impairment to normal or near normal visual acuity. A child with CVI may have unique characteristics as shown here. Now let us understand why we need a separate CVI clinic. Examination of a child with CVI is time consuming and hence it is not possible in a regular busy pediatric ophthalmology clinic. Having a separate clinic allows us a thorough functional vision assessment with involvement of the dedicated staff and provides adequate time to evaluate the child and also counsel the parents and plan their individualized strategies. The examination room should be away from noise and chaos, providing adequate movement area for the child. It should have plain walls with good natural light and ventilation, should be uncluttered and should provide comfortable sitting area. While these are the simple materials that one can use in the clinic for examination, one cannot underestimate the patience and the dedication one requires to do justice to the examination. The primary goal of the first clinical evaluation should be to perform a comprehensive eye evaluation to specifically look for any treatable problem, while the second visit is aimed at understanding the child's functional vision. When there is evidence of some vision in the child based either on the visual behavior or on the history, one can do the preferential looking test using the tag card or the LIA paddles, which help the parents to understand the optimal line thickness and separation between the lines which their child can appreciate. When the child does not respond to these, they may respond to puppet or smiley faces, and sometimes adding a movement cue brings out a better response, as some children prefer moving objects versus a static one. In children where the visual acuity cannot be assessed, look for their various visual behaviors. One can use illuminated toys, shiny paper cards or pom-poms which are held in different directions for an adequate time until a response is elicited. For a higher functioning child, vision on LIA symbols, HOTV or Snellen's chart can be done. For color vision assessment, one can use illuminated balls of different colors or use colorful puzzles and play color sorting games. For contrast sensitivity, the hiding-Heidi test helps us in understanding the optimal level of contrast. One can use smiley faces or LIA wand to assess visual fields in a low-functioning CVI child. Saccades can be assessed with the use of colorful filter paper or by using a colorful object shown through a toy with a window. For testing pursuits, we can see if the child follows a slow-moving target smoothly. One can assess hand-eye coordination by asking the child to stack blocks or rings or put colorful balls in a container. In high-functioning CVI, one can assess cognitive visual dysfunction by doing LIA puzzle test, which helps us in understanding how the child grasps the symbols, matches the color and shape, orients the symbols and put inside the slot. In the LIA mailbox test, the child is asked to pose the white card through the slit in the yellow circular disc. Note how the card is grasped, oriented and posted through the disc. For assessing motion perception, child is asked to count fingers while it is still and while waving the hands. Increased speed makes child unable to count fingers, thus explaining this kinetopsia. For assessing simultagnosia, one can ask the child to pick up a certain toy from a group of toys in a basket. For the ease of assessment and understanding the child's visual function well, one can use a structured clinical question inventory like shown here. Now let's look at what strategies we can employ in low-functioning CVI child. Before starting any visual training, ensure that the child's posture is comfortable to enable him to use vision well. In a child with severe visual inattention, one can start stimulation using illuminated balls while adding sound and making the child feel the ball so that it gives them a good sensory experience. A simple feeding bottle with black stripes on it corresponding to the child's visual threshold with added warmth and smell of the milk can create an unforgettable experience for the child. Encourage the mother to enhance her facial contrast by applying a big bindi, kajal and bright lipstick, and for the father by wearing black colored glasses or growing a mustache or a beard. Encourage the parents to interact within the child's visual sphere, speaking slowly and with repetitions along with tactile inputs. One can make use of familiar objects with single or contrast color with additional tactile cues. One can also enhance the contrast by providing food in contrast bowls. Now let's see what strategies can be used for high-functioning CVI child. Children with CVI often struggle with reading and writing, and hence encouraging them by wearing their refractive corrections, using bigger and bolder picture or fonts, use of phonetic words and typoscope improves their learning experience. Difficulties in object size and color awareness could be eased by engaging them in various activities like seen in this video. One can improve recognition by using several puzzles, colored balls, textured cloth, and toys with different shapes. Children with simultagnosia find it difficult to identify objects when they are presented to them in a crowded manner. Hence, keeping it simple and one thing at a time allows them to explore better. A child with a field defect could often miss food on one side, and hence rotating the plate could help. Similarly, a child could also be helped in a classroom by providing a proper placement to maximize their visual function. Child with an inferior field defect may miss the steps while climbing down the stairs. Such children could be taught to use the movement of their body with tactile cues. Children with face blindness could be helped with the use of non-visual and non-facial cues. Difficulty in navigation and mobility could be assisted by encouraging holding the railing while climbing the stairs, or by using walkers or floor highlighters with tactile guidance. And in very severe visual impairment, use of a white cane or a human guide could help. Hand-eye coordination can be improved by simple stacking ring activity, use of a Marsden ball or a pegboard, and by giving therapies on multisensory systems like the SVI. So let's make a difference in the life of these children, as it is not a lost cause. Early detection would lead to early intervention and improve their quality of life. Let's aim not to make the child normal but independent. And remember, any therapy will not be expensive.